and now we are pleased to introduce Dr. David Morrissette, Ted Lutterman, and Dr. Justin Trevino to discuss state implementation of crisis bed registries. Dr. Morrissette is a consultant with NASMHPD Research Institute and has been instrumental in helping states establish service registries. Ted Lutterman is Senior Director for Government and Commercial Research for NRI. Dr. Trevino is the Medical Director for the Ohio Department of Mental Health and Addiction Services. Thank you all for being here today. Now I'm going to turn it over to Dr. Morrissette. Thank you.
And Dr. Morrissette, you may be locally muted on your end.
There you go, sorry. With recent funding from SAMHSA's block grant set aside, this is a great time to be thinking about assessing, reconfiguring, and deploying crisis services. And SAMHSA's National Guidelines for Mental Health Crisis Care Best Practice Toolkit outlines the array of services that define the comprehensive crisis system. And it recommends the use of bed registry technology to support the coordination. I'm going to take a few minutes to tell you about what a bed registry is and sort of in preparation for Ted's telling us about the update. So bed registries in the most basic form are web-based electronic databases or inventories of filled and unfilled beds in behavioral health settings. These can be mental health and substance use, crisis, stabilization, and treatment settings for children, adults, or both. And the settings may include inpatient units in public and private hospitals, crisis stabilization units, detox centers, crisis respite, and residential settings. Building on this inventory, what we found is that states are using bed registries to organize and monitor resources and to coordinate the movement of people across services and systems. Over the past Over the past 2 years, NRI has been following the progress of 23 states that received TTI grants from SAMHSA through NASMHPD to establish or expand bed registries. This presentation is based on interviews with the TTI project directors, and you can find two-page fact sheets about each of the state projects and a summary of NASMHPD's at NASMHPD's publication webpage. States are building bed registries based on the problems that they were trying to address. So while the primary goal of bed registries is typically to get people into care more quickly, some states were also under executive or legislative mandates or Department of Justice suits that further refine the purpose of define the system. State agencies also are building bed registries to address problems such as excessive waits in hospital emergency departments, to support their mobile crisis teams, and to directly empower consumers, or to divert hospital admissions, or to make these resources that they have available and accessible and visible, transparent to all stakeholders. Many of the project directors told us that bed registries are not really software projects, they're community engagement projects. As documented in the previous studies, successful bed registries are those that engage stakeholders. Stakeholders must have an input into the design to ensure that it has value to them. Otherwise, these bed registries can seem like just another layer of administrative process that gets in the way of providing care. This chart reflects the stakeholders engaged in planning processes across the 23 states. And you'll see that hospitals were by far the most involved in the planning process. Projects engage their stakeholders in different ways, through new or existing planning committees, focus groups, or caucuses at conferences. Bed registries fell into one of three broad categories. Search engines were the most common model, and as the name suggests, bed availability is compiled into a web-based database that users can search. In the second model, referral systems, authorized users can send HIPAA-compliant electronic referrals to bed providers through a website. And in the third model, referral networks, any authorized member can both send and receive HIPAA-compliant referrals through a website. Search engine websites can often be accessed with a phone app, and some using GPS can locate the facility closest to the caller to provide driving directions. Other sites like Massachusetts have searchable databases that include many other behavioral services such as in-home care or peer support programs. Several states include residential and community housing programs in addition to the crisis beds. And a few states are launching search engines that interface with facility electronic health records to automatically update bed availability, overcoming a significant administrative burden for the bed providers. With search engines, finding a bed or service on the website is the first of a two-step process. The second step is calling the facility to secure an opening. Referral systems were developed because so much time and effort are spent securing an open bed. People have to call, they have to fill out lengthy forms, and they have to fax. So 3 states created these bed registries that not only list available services, but support the electronic submission of referral forms. Stakeholders were very involved in the designing of the forms. Authorized users can locate an opening on a website and submit a HIPAA-compliant referral electronically and even get an answer back. On Georgia's dashboard shown here, system managers are able to track the pending status of patients as they move through the system. 6 states are using the same vendor, Open Beds, to establish referral networks. Network members can both send and receive electronic referrals. Through the network, for example, an inpatient unit can receive an electronic referral for a bed and also make a referral to a community agency for outpatient services, as shown here. The types of beds that are included in bed registries varied a lot across the states. The most common type of beds were crisis stabilization units. Public psychiatric hospitals were slightly less likely to be included, followed by private hospitals. And it should be noted that not all private hospitals in a state or a region participated. More than half of the states include substance use disorder settings in their unified bed registry. About 1/3 of the state registries include beds for children and youth. About 1/3 of the states use registries to track community residential beds to support transitions from hospitals to community. 4 states include crisis respite settings. The most important characteristic of a bed registry is whether it contains accurate and timely data. For a number of reasons, including staff turnover at facilities, this has been one of the most challenging. Finding a balance between the accuracy of the data and the administrative burden it places on caregiving staff is a key issue to engage stakeholder input. Most states, as reflected in this chart on the right-hand side, found that the balance occurs at shift change, 2 or 3 times per day. This has been a particularly crucial issue during COVID-19 pandemic response, as facilities reduce capacity to reduce risk and accommodate state staffing shortages. The next most common refresh rate is once per day. Automatic electronic updates occur in real time as facilities process a discharge or admission record, or as systems update at 15-minute or hourly intervals. Georgia requires its contracted bed providers to manually update availability in real time. Most of the projects approach bed registries as tools for professionals, and so that they restrict access to only authorized users. A few states make the bed registry website available to the public. Open Beds provides two portals, the referral network for authorized users to make and receive referrals, and the search engine open to the public. Among those that are authorized users of the bed registry, most often they're the participating hospitals that provide data on bed availability. And they're followed by mobile crisis teams, emergency departments, and local behavioral health authorities, underscoring the main purpose of bed registries, to get people in crisis into care. There was not an apparent relationship with crisis call centers in most states. Do bed registries work? Well, it depends on what you're trying to do. Most data collection is around the time to treatment element. Referral systems and referral networks collect information about the time it takes from referral to treatment admission. In addition, several states use other data such as waiting time in hospital emergency departments to gauge whether the state's crisis system and the bed registry are reducing delays to treatment. Bed capacity and utilization form the next most common group of measures. Search engines, referral systems, and referral networks all collect and report bed capacity of individual settings at least daily. By comparing the daily volume across bed types, states can see trends in the use of respites, crisis stabilization units, private and public hospitals, and across regions of the state. Several states are using the bed registry to monitor policies and protocols to divert referrals from state hospitals to local hospitals or from hospitals to crisis stabilization units. Referral systems and referral networks are also able to report on providers' responsiveness to electronically submitted referrals. How quickly do they respond, and do they accept or deny the referral? Several states, particularly those seeking to use bed registries as transparent and user-friendly systems, are interested in the satisfaction of users and providers. Other measures include the impact of the bed registry on other services such as the volume of calls that a call center receives. So with this brief introduction to bed registries, I'm going to turn things over to my distinguished colleague and boss, Ted Lutterman. Ted?
Thank you, David. I'm not so sure about the distinguished colleague, but I want to start out by thanking the 23 states that are working on the crisis bed registries, as well as several other states that aren't part of the TTI process that have registries, because they've been so open and willing to share their experiences and lessons learned with their peers in other states and with us. And I think that's really been beneficial for helping people avoid reinventing the wheel and learn from each other. Now, a lot has changed in how states are working on their behavioral health crisis services since the 23 states received their TTI funds to work on registries back in 2019, and we first started documenting their work. First of all, the pandemic from COVID-19 greatly impacted delivery of behavioral health services with major disruptions in normal services, especially at the inpatient psychiatric level, where many hospitals had temporary unit or bed closures due to COVID exposure. Also, Congress added a 5% set aside to the mental health block grant, $42.5 million for states to work on expanding a behavioral health crisis continuum. And then in 2021, with the COVID block grant supplement, they added an extra $42.5 million for states to work on crisis services. And the SAMHSA guidance to states listed crisis bed registries as an area where these new funds could be used. And finally, last year, Congress passed a national 988 suicide crisis line that's going to go live a year from now in July of 2022. And none of those existed when states first started working on their registries. So with all that going on, in talking with new states working on this, we thought we really needed to update how systems are working today, how they're adapting and being utilized with these major system changes. So in June,
we sent out an online survey to all 23 of the original TTI states, and I'll talk today about results from 20 of the 23 states. We're hoping to get the last 3 states in, and then we'll be putting a report up that'll be available from the NASMHPD website. The survey asked about the current operations of the registry and any planned changes, how COVID impacted the operation of the registry. We also asked states how they're planning to include the use of their registry in their larger crisis continuum that they're working on with the block grant and other funds, and how the states are planning to use their registry with 988. And finally, we asked them about their lessons learned, advice to new states working on bed registries, since SAMHSA and NASMHPD just funded 7 new states this year working on establishing bed registries. Regarding the current operation of bed registries, the responses suggest that the registries are constantly evolving and growing. Over half the states reported they're in the process of changing their registry. Several are looking at changing their software, their vendor for running the registry. But states are especially expanding the number and types of services and providers that are in the registry. Some states are including additional inpatient providers, but many states, as David said, they cover other services besides inpatient beds, and so they're expanding the inclusion of residential options, respite options, crisis receiving centers, mobile crisis, trying to make sure that when somebody's in a crisis and they hit the registry, we don't just put somebody into a bed, but we determine what's the best placement appropriate for the person and help find that service. Several states are also exploring how to make their registry more automated. As David emphasized, one of the things we've heard is the registry needs to be current and timely in order to be accurate. And so several states are looking to link their service registry to electronic health records or health information exchanges to automate the registry. Another thing we heard was that registries don't need to start statewide. Especially in a large state, it may be a reasonable approach to start with a regional implementation. So 4 states reported that they've initiated the registry in 1 or more sections of a state instead of going statewide. And most of those states are now in the process of building out on this, based on the success of the registry in one region, to expand to additional areas of the state. And after I talk, Dr. Justin Trevino, Ohio's medical director, will share Ohio's experience where they started the registry in one region and now they're expanding it to several adjacent counties around that region. States also told us it doesn't cost that much to buy or to run a registry, costs running from $25,000 to $500,000 per year. But I do want to caution, I don't believe those costs include all the time that the state staff are actually spending out working with providers and with stakeholders, designing and supervising the system. And again, as David emphasized, over and over we heard that the stakeholder engagement and state leadership is a key element. So while it may not cost much that you need to budget for outside, states, we're cautioning, really do need to make sure that you've got staff available to lead this effort and to spend a lot of time working with your providers and stakeholders. States were supporting the registry to start with the TTI funds, but also 6 states are using general revenue funds, 5 states are using the block grant, especially with this new flexibility SAMHSA indicated. And 1 state's already using Medicaid to pay for part of the registry operation. And just this year, guidance from both SAMHSA and the Medicaid CHIP Payment Advisory Commission for Medicaid highlight that both the SAMHSA block grant and Medicaid administrative match can be used to support crisis bed registries. The goals that we heard from states in terms of their using what they want to use the registry for are very much what they were last year. In David's slide, of the 20 responding states, 16 have operating bed registries, and 4 states are still preparing to implement their bed registry. Several were delayed because of COVID. But for both states, the most common goals of the registry, they want to reduce emergency room waits, they want to divert people to less restrictive settings, increase placement options, which again means many states are not just focusing on inpatient beds, but looking at a variety of beds or crisis services, reducing the distance to placements, finding the closest appropriate bed, diversion from incarceration. And I thought it was interesting, the evaluate effectiveness of policies popped up in a number of states. So as they're changing their system, they can use the registry to monitor how their system changes are going. One of the things, again, over and over we hear is that in order for a registry to work well, it needs to have timely data. And unfortunately, during the period of COVID, we heard that it really stressed reports. So 71% of the states reported that they were having challenges receiving regular or timely updates of bed availability, especially during COVID. We asked them the major reasons, and this sort of word chart highlights some of the things that states said. The major reasons, staff turnover, especially during COVID. Having different staff on weekends from the weekdays may lead to drop-off in reporting on the weekends when people are really likely to get stuck in emergency rooms. Overall burden of reporting if it's manual, changes in facility leadership, a lack of understanding of the importance of updating regularly. One state said they addressed this by developing automated notifications to facilities that are not updating, and then they follow up. The registry staff go out to the facility, work with them to resolve the issue. One state added that we've experienced staff turnover at the facilities so much that we keep having to train new staff. We're looking into a more computerized way to update the beds so it will not be dependent on a human to input this information. States are also looking at most effective ways to incentivize participation. And over what we heard is it's not a mandate. That mandates required reporting isn't nearly as effective as stakeholder engagement, identifying ways to get them. So publicizing the project to key stakeholders and leadership galvanized interest and demonstrated the value of participation. The state said that by designing something that's relevant, appropriate, and adaptable for placement process, it increased it. Another state said by providing ongoing support, communications, and training, as well as accountability through dedicated staffing. They said only 12% of their providers have a contractual obligation to use the registry. So the majority of users are voluntary users, but by providing a no-cost system that helps even the smallest providers find available beds, it really helped. Another suggested that they encourage participants to update the registry by letting them know that referring sites will be less likely to send patients to sites that don't update their beds. That helps them make sure that any available bed they have does get filled. States made a number of enhancements to the registries during COVID. 2/3 of the states said that they found the registry increased in value during COVID because it was able in real time to identify closed units or beds, making it more valuable to the behavioral health and emergency providers. But a third of the states reported that they had some decreased use since COVID, or due to COVID, because, again, the data wasn't being updated as often. Staff were out or just not updating as much, and so the system became less useful. And if it was less useful in terms of timeliness of data, available beds, the use dropped off. One of the things that states that increased the utility did was a number of states increased, they added units to the bed that tracked either quarantine or isolation beds. A third of the states added information about temporary program or bed closures due to COVID. States added information about blocked beds, changes of admission policy. They included in the registry information about what kinds of COVID screening were necessary for people before they could be admitted to a facility. And in follow-up interviews we did with several of those states about how their registry worked during the pandemic, they said that if the registries were able to add this kind of COVID-related information, such as tracking closures and changes in real time and changes of admission policies, that it really helped the state increase the value of the registry. It let the state monitor both to get people placed into services timely, but it gave the state a better public health oversight. So the state could see whether certain regions of the state or certain client groups, for example, children, that were really having a difficulty because of beds being blocked, and the state was then able to step in and make sure that services were brought up for those groups. In terms of how states are looking at using their bed registry as part of the larger behavioral health crisis continuum that they're developing with the new block grant funds and other funding, states report wanting to use the registry as an important tool to manage and monitor their crisis system. As states are working to expand crisis call centers, mobile crisis stabilization, residential crisis services, they're looking to use their block grant as an active part of monitoring the system and referring people to the overall crisis system. You see it as a way to identify choke points in their system and to track where people are getting placed and where they may need to expand, either geographically in a certain region of a state or particular types of services, maybe for kids, for adolescents, for people with co-occurring that may need to be need expansion. Similarly, we asked about Crisis 988, and states are looking to include 988 with their system. Many states are still figuring out exactly how 988 will work, but 11 states said that they're going to allow 988 systems to access the registry to identify current placements. The last couple things briefly, we asked states what were their lessons learned for states as they're going forward with this. And I think we got some great responses there. You know, this is not a technology project. It's a stakeholder engagement project that you need to work with stakeholders to determine what's needed and requirements, and only then identify the best IT system. Or another great comment was that a bed board, a registry, does not fix your system's problems. It will only highlight weaknesses of the system, that you need a full continuum of crisis services, and the bed registry is a good tool to help manage that system. And there's some other nice comments. In terms of advice to states working on developing a bed registry, we sort of grouped them in terms of, you know, implementation. You need to have stakeholder engagement from the start before you develop your system design. Get them on board about what the need is. Work with them through implementation. Provide lots and lots of training. And finally, be flexible. The state stressed that the system changed throughout as they're working on it. You can't plan for everything, and if you could, something will change. So make sure your design can be improved as needed. And finally, be patient. So with that, I'm going to turn it over to Dr. Justin Trevino, who's going to talk about Ohio's work on this. Here's again a link to the report and our contact information. Thank you very much.
All right, I'm going to just start talking. I so appreciate being invited to this meeting, and I will be really succinct with a few points. We started with a regional implementation in Ohio. That was a strategy decision. We have 4 or 5 major urban areas in Ohio. The idea was to create a concentration of activity and a network that would then prove as a pilot implementation, and that we could then transfer to our other urban and then rural areas, thinking about the different strategies that would be needed in those different regions of the state. It is about relationships. I think that last slide before I came on is so important. It is about relationships. So who did we pick to relate to in Ohio? Our alcohol, drug abuse, mental health boards really convene a lot of stakeholders. So when we went to, this is Cuyahoga County and surrounding area, that's Cleveland area, we definitely started with Cuyahoga County Adam Board to be our convener, and that was very successful. We also used a major hospital up there, University Hospital, and we appreciate their support. But picking the conveners, we additionally engaged our statewide associations so they knew what was going on. That's so important, I'm sure, in every state, but people want to know in Ohio. So our board associations statewide, our provider organization associations, our hospital associations, and our NAMI, our advocacy organization. So that was very important. This takes a lot of effort, as was said, day in, day out. I'm involved, we have other staff involved, but it is truly an ongoing day in, day out proposition in terms of engaging the stakeholders out there, presenting the product, hearing their experience, trying to move forward with this in a holistic way. We knew this would get way beyond inpatient psychiatric beds. That's what our plan was, and it's really going in that direction. We have a very ongoing presence with our vendor. We meet weekly. I'm missing our meeting this week, but I got good support there. We meet every week to coordinate and talk about new developments and how things are going. So we really know exactly who's coming on the network and what their experience is, what the new services are. We invite people internally from our department, have a pretty open forum in terms of different classes of providers or even services. We've talked to our housing folks, our recovery folks in our department to understand their world, their environment, our child serving folks. And I think the last point I'd like to make that was made, 988 then comes into our world, and we knew that very early, and our vendor was already thinking 988 when we engaged them. We have made them a part of our department 988 work group, so we're trying to do this lockstep the best we can, and I think that's really going to serve us well, that we got this whole thing lined up as it evolves, and we're all talking to each other and trying to see how that world works together. Those are a few of the major points I wanted to bring, and I appreciate having the opportunity to do that. So thank you for the attention and the forum here. Appreciate it.
Thank you, Justin and David, Ted. Excellent presentations, and I think the material that's been presented on this hour will be of great interest to our states and divisions. So thank you, everyone, for attending. Our August 19th Meet Me Call webinar will also be an extension of our NASMHPD annual 2021 meeting. We look forward to everyone attending August 19th for our next meeting that will be the third Thursday at noon Eastern Time. Thank you very much.